vaccination questions. I'm sure we'll have many returning attendees given the positive response we received from session 1. So welcome back, everyone. Particularly delighted to welcome back Dr. Shannon Magari. Shannon, for those of you who weren't here last time, is principal owner of Colden, based in New York, and serves as the Vice President of Health Sciences and is co-chair of the litigation support practice. She aids clients in determining the origin and nature of workplace health concerns and provides litigation support in suspected cases of occupationally or environmentally induced illnesses. Dr. Magari and her team have helped to develop COVID-19 safety plans, conducted workplace audits to protect those working in industrial and non-industrial settings across many sectors. So in today's webinar, Shannon will be looking at the hierarchy of controls for COVID-19, as well as providing a recap on session 1. It was an extremely informative webinar last time, and if you missed it live, you can watch it back on IIRSM's YouTube channel. Please submit your questions as we go along, and we'll have time for Q&A at the end of today's session. So Shannon, thanks again for joining us. Welcome back, and over to you.
Great, thank you, Claire. Good morning, good afternoon, wherever you are in the world. Thanks for joining us again. I am excited to present today. We've been doing a lot of vaccine education. I've got a nice section of vaccine recap from the first session, and I'm sort of trying to forward think as best as we can, and unfortunately a lot of our colleagues around the world are in the thick of things still, but I'm going to talk for about 35-40 minutes. We thought we'd leave 15-20 minutes at the end for questions, so we could put those in the chat section, I think, or is there a question section, Claire, and then we can have some dialogue at the end, because I think that the sort of thoughts on, you know, going forward, a 2.0 plan are going to vary widely based on where you're at now, you know, what resources you have available, what your company culture is, and a whole bunch of other things that maybe we can't even predict right now. But I wanted to start with just sort of a little bit of the lay of the land around the world. I pulled this from the Times yesterday. This pandemic is not over. There's some bright spots around the world, and there's some tragic spots around the world. And so this spike were larger than the peaks even of this past winter around the globe, and it's largely fueled by these peaks and these hot spots, for lack of a better word, around the world. So you know, India, Brazil, Argentina, Turkey, you know, it's nowhere has been immune, and you know, we sort of thought some things were looking good for India last year, and now look at the situation we're in there. Same thing for Brazil. We thought we had some herd immunity, and you know, things are heating back up again, and pretty much all of South America. And I fully recognize that the focus of the presentation was COVID 2.0, you know, forward thinking. Totally recognize that some of us are really still in the thick of it. And so no matter where you're at, again, we want to draw everybody back to what we know works, right? Back to our hierarchy of controls. And what can we take advantage of at different stages? You know, the ultimate elimination strategy is a vaccination. That might not, you know, happen for weeks or months for many of us, right? So what else can we do in the meantime? What makes sense? Depending on where we're at, you know, what maybe can we pull back on, right? Science-based, you know, risk-based, what can we sensibly pull back on? And it's funny when I speak with my colleagues here, you know, it kind of was almost easy to tell everyone to go home, right? And work from home, and because we didn't know a lot, right? Now we know more. Getting people back to work and actually taking things away is going to be more difficult, right? When do you stop doing things? And what kind of evidence do you need to stop doing something? Because it was so easy to use a precautionary principle to send everybody home, right? To stop. So I'm going to sort of structure the presentation on each one of these slices of controls and what we know works, and you know, what the rubric might be for pulling back if you can. And before I start, I want to make sure that we're all on the same page about the routes of transmission and that we're all very clear about where the major risks are falling. We had a great follow-up paper from our colleagues at MIT, the aerosol physicists there and the mathematicians there, that underscored what a lot of us health and safety professionals have known since last February or March, right? Which is probably the largest route and the biggest concern, the risk we need to mitigate is aerosol transmission. So those things that are less than 5 microns in diameter, the particles, the droplet nuclei that are essentially have no mass, they're going to remain airborne for very long periods of time. They're the things that we need to dilute out and filter out. So ventilation, ventilation, ventilation. We've got new guidance on the fomite route of transmission and how low of a risk that is. Thank heavens we can sensibly, science-based, pull back on some of our cleaning now. And then there was this sort of large droplet transmission, which is great. You know, we're going to mitigate that with distancing and things like that, but still a risk. But really making sure that we're all truly recognizing the aerosol route of transmission and how important that is in mitigating risk. Quite frankly, we, last Feb and March, us epidemiologists, the engineers, our certified industrial hygienists, were looking at these numbers going, of course there's an airborne route to this whole thing. We would never get these numbers, this rate of spread, and the slopes on the curves if there wasn't, right? And so the US CDC didn't recognize this until October, and then everybody's still a little hesitant about using the word airborne, right? Because it's a scary word. But we know what to do, okay? And so again, we'll start walking through the hierarchy of controls, which says the ultimate strategy is to eliminate a hazard. If the hazard doesn't exist, nobody can get hurt or sick, right? So we've been doing a lot of screening. We've been doing a lot of symptom self-checks, temperature screening, these types of things. The temperature screening, I've got clients who have, thousands of people campuses. They pull 1 or 2 people a week, which absolutely is helpful. Everyone's got to sort of decide, do you want to have, because people that are sick shouldn't be welcome at work anymore, right? And this is kind of one of those things where, maybe this should never go away, right? I mean, and perhaps it bucks decades of culture, which is just slog it out and get to work, right? Just, you got the sniffles, just go to work. But you know what? Like, sick people shouldn't come to work anymore. And so maybe we move from complicated temperature screening at the work site to some sort of self-checks in the morning before you leave. Maybe you have to attest that you've taken your temperature in the morning. Maybe it's just part of, getting up and brushing your hair and brushing your teeth and taking your temperature, right? Like a new normal on, am I well enough to go to work? Is going to emerge. We're actively watching some very cool new technology in portable mass spectrometry to look at exhaled breath screening. So looking for actual breath signatures in for oxidative lung damage. People exhale thousands of different signatures based on various pathologies. We've known this for a while. And the COVID signature for VOCs is actually pretty distinct. Some of these tools are so good. They're looking for filings based on screening, but they're so good they could be used as diagnostic tools. So, hopefully later this year, a lot of them are being actively trialed around the world. There's 3 that we're watching actively. There's also some portable mass spectrometry to look for actual proteins, right? Actual virions, and those are highly diagnostic. So, stay tuned on the screening front. A lot to come, a lot of science to come pretty quick, maybe by the end of the year, hopefully. In the realm of eliminations, there's the screening tools to keep sick people out of the workplace and eliminate the hazard. I want to talk to you about testing. I think in general, the States for sure has lost sight of testing. Testing volumes have dropped tremendously in the last few weeks, and it's scary, right? It is absolutely remains and will remain a critical tool in keeping sick people, eliminating them from the workplace. And then last, I'm going to recap in our bucket of tools, elimination tools. I'll recap some of the powerfulness of the vaccine, because the vaccine is the ultimate elimination. But stick with me for a couple of slides on testing and how important that is. And I think no matter where you're at, again, in the rubric of how cases are looking in your area, testing is going to be important, and the policy around it is going to be super important. Okay, and who gets tested is the first critical question, and I've got a lot of clients who are still routinely testing public facing folks, like a lot of major libraries in the US. They're doing as they open up to the public again, doing a lot of testing on the front facing folks, folks in grocery stores, this type of very high volume public facing person probably should continue to get tested. Is testing the unvaccinated a strategy? I've got a whole section here we'll talk about how do you accommodate the unvaccinated, and testing, routine testing for those folks that can or won't get vaccinated absolutely should be a conversation to have. Maybe a random sample of the unvaccinated, or a random sample, certainly if you've been vaccinated and you have symptoms, you should get tested. So the who should get tested, we should start the conversation with. The which test, boy, this is complicated, right? So early on, supplies were limited. Some tests went out that were kind of faulty, which was unfortunate. Testing availability is definitely improved since we were having this conversation a year and a half ago. We want to make sure we're understanding the difference between diagnostic testing and screening testing, okay? What that means, okay? And so just lay of the land here, we have generally 3 types of tests. We have a molecular test, which actually tests for the virus, okay? Some of these are lab-based, take a day or 2 to process. Some of them are rapid, so these are your PCR tests. The rapid tests, similar technology, have a higher limit of detection, right? Because you don't have the time. They're rapid. You don't have the time that you have in the lab to run more cycles. You have an antigen test. So all antigen tests are rapid, okay? Both of these tests, so that looks for different proteins that the either on or the virus produces. So both molecular and antigen tests are what we call diagnostic tests, right? They're going to help us diagnose sick people. The antibody test is a look back, okay? And some interesting things are going on there. We shouldn't use those tests to diagnose folks. I know early on folks were doing those. Some of them are quick. Some take a couple days. The antibody tests were sort of, everybody's been focused on vaccine passports. Now I got a lot of clients, largely in the entertainment sector, that are focusing on immunology passports, right? So, okay, you got vaccinated, that's all well and good. Prove to me that you're actually immune. Prove to me that the vaccine worked for you. And that's where we're going to see some interesting things develop, and the types and varieties of antibody testing, looking for cellular immunity and humoral immunity, all those kinds of things. But suffice to say, as screening tools, if we're going to stick with our hierarchy of controls, we're in the elimination bucket. We want to screen employees. We're going to be in one of these 2 buckets of molecular or antigen testing. And which one which, right? So which one to use? What are they good for? And I'll tell you this, all of those tests were developed for use in sick people. They're the most predictive. They have the most positive predictive value, we say. People that have symptoms, right? And or people that have been exposed, right? That we generally think might develop symptoms, okay? They were never meant to be used generally as screening tools. So as a screening tool, right, bumps and warts are going to develop, right, for lack of better words. But let's just run through where the difference is between maybe your highly sensitive lab-based PCR test, right, and something with a little bit more analytic sensitivity like an antigen test, okay? And what are they good for? So the highly sensitive PCR testing is going to detect someone who's sick, okay, depending on when they start having a spike in their viral load, between when they're exposed to when they spike, okay? It's going to be very sensitive, right? But may not catch you early on enough, okay? It's an expensive test. It's not something you would do every day or every other day, okay? But it's sensitive enough. People are testing positive for the virus many weeks after they've moved through their infectious period, right? Which is hard, right? They're probably still safe to move out in society, but this test is so sensitive, it's picking up and amplifying tiny little pieces of virus, right? And labeling someone as infected, but not necessarily knowing if they're infectious, right? So there's a difference. Contrast that high sensitivity test, something lower sensitivity like an antigen test that can be done for a couple of bucks and repeated 2 or 3 times a week. That's where the power of something with low sensitivity comes in, when you routinely do it. And so you can see something with lower sensitivity is going to pick up somebody's infectious period. So the antigen tests are better when you're infectious, when you're actively infectious. That's when it's going to catch your turn positive. So the antigen tests repeated more frequently, even though they have a low sensitivity, may actually help us narrow down on somebody's infectious period when they should be eliminated from the workforce. They should isolate, get better, okay, and then can reenter society in a smaller time period, okay? So there's a place for both the lab-based PCR, the rapid PCR, all of the rapid antigen tests, recognizing fully their limitations. You're going to end up with false positives, false negatives. You're going to need policy pieces and strategies to deal with the false positives and the false negatives. I'm not going to run you through a complicated stats conversation, but the point here is that testing is still really important. Again, screening is difficult. You're going to have to deal with some people turning positive and having to go get a second test and isolating for a day or two while they wait for results. We're also going to have to deal with some false negatives, whereby somebody actually misses the screening, right? But even at something that's 30 or 40% sensitive, you're still screening out folks. And I think that's important. I don't think we should be looking for a perfect test, right? That we have strategies to deal with the limitations. Okay, so just keep that in mind as you're sort of sorting out where testing is gonna fall into getting back to work, and it may be targeted at the folks that can't or won't get vaccinated, as a thought. So the ultimate elimination strategy before we leave our hierarchy of controls elimination bucket is vaccination, right? I mean, V for victory, V for vaccine. This is how we're going to get out of this mess, okay? Crazy diversity worldwide, and where the shots are going, and the efficacy of programs and things like this. So we've got some countries around the world, we're getting close to 50-60% vaccinated, and some places we know aren't going to get vaccinated until next year, right? So crazy diversity. Here's a list of the top 14, and some small countries are leading. We've got US, UK, right up there, and Israel's doing great. And I want to just point out here, we're going to talk in detail about the vaccines, but I want everyone to sort of let go a little bit of the concept of herd immunity. We don't even know what that number is, 80+%. Probably we're not going to get there anytime this year, probably in a lot of locations, but some very nice things are going to happen along the way, even at 40, 50, 60% vaccinated. The death tolls are coming down in these locations. We're starting to clear out the hospitals. So, every inch we can make counts, right? Even if we're not reaching that herd immunity. So as you're looking to get back to work, what does your vaccine policy look like? And man, the rules vary worldwide about what you can and can't mandate. It's probably the most important thing to be having conversations about, everywhere from mandatory to incentivize, encourage, and then just support. Although I've got a lot of clients using that word. I'm not exactly sure what that means, other than doing some good education and giving people time off to go get it. I don't have a lot of clients outside of healthcare that are mandating it right now. And with, at least in the States, with the emergency use authorization, they don't have full approval. Hopefully in the next few months will apply. Pfizer and Moderna plan to apply. You need 6 months of data in the States to apply for the FDA for full approval for any kind of drug. So that should be happening soon. But outside of the EUA, which has very fine print that says You have to offer folks the ability to accept or refuse the vaccine. Mandating it makes it very difficult. Okay, so I think the mandates are going to first come in healthcare for sure. And then I've got a lot of higher ed clients who are dancing around this, and they've sort of almost pretty much said mandate. So outside of healthcare and higher ed, I really don't have anyone doing this. But the rules are different around the world, and maybe in some places you totally legit can, and that culturally that's going to be fine. At the very least, I'm actively encouraging all employers to take a role in educating folks, sending them to vetted resources, whether it's the World Health Organization, US CDC, whatever, you know, the National Health Service, and whatever government vetted agency you can direct folks to, the better. There is so much junk out there on social media, and just there's too many people talking. I think being able to at least direct people to where your organization is confident the information is true is going to be the minimum I think folks should try for. And then this last one, I mean, this seems to have become the third rail. If you know, at least you're going to mandate, are you going to ask, right? So as health and safety professionals, we have to anticipate, recognize, evaluate, and control hazards in the workplace. And if I don't know who's not vaccinated or vaccinated, I can't do anything about it, right? I can't control the hazard. And you know, this is a small group and will contain this conversation, but the unvaccinated are a hazard, and they need consideration and respect and all those kinds of things. But I can't do anything if I don't know where they are. And so you just continue to default to the most conservative recommendations. If you, again, using the precautionary principle, if we don't know. So asking, I think, is actually pretty important. And again, that may be off the rails for rules, for HR rules, and maybe not, but definitely something to think about. And, you know, so folks have said to me, okay, well, that's great. You're going to ask, what the heck are you going to do with that information? I think there's a lot we can do to accommodate the unvaccinated. Again, you know, and I left a bunch of blank spaces because this conversation has got to continue. You know, should folks be allowed to work from home, to continue to work from home if possible? Do they need to be reassigned, you know, to a different job or a different office space or whatever it is, right? And I get it, the HR issues abound and the opportunity for malingering and whatever, I get it, but it's part of the conversation. For sure, I think the unvaccinated need to continue wearing masks. I don't think any of us are going to be out of masks for quite some time, probably not till the end of the year or beginning of next year, but for sure, if they're not vaccinated, in my opinion, they got to scientifically got to wear a mask. Routine testing. I've got a number of entertainment clients that said, look, if you're not going to get vaccinated, you got to get tested twice a week. I actually even had some that said you need to get tested twice per week at your expense, which I think is dicey too. But again, you know, we're all trying to figure this out in real time. And what should the unvaccinated be allowed to participate in? Should their restrictions be moved? Can they not participate in in-person meetings? Should they not be allowed to travel to other company offices? Or maybe they're only allowed to travel domestically, not internationally. A lot of conversation needs to happen here. And I get you're creating two classes of citizens and all the issues that are associated with it. But we're going to have these painful conversations for some time. I wanted to address how to talk to the hesitant, and this will largely just sort of recap what happened in the first webinar. But I think the first thing, you know, I'm developing a callus on the end of my tongue about the unvaccinated, and as a public health professional, we've got to figure out how to talk to everybody, right? I don't approach these conversations as a debate. It's just a conversation. I'm not trying to win points. I'm not trying to absolutely win someone over. It's just an open-ended conversation, a compassionate listening conversation, because actually some of these people are genuinely scared, right? And need questions answered, right? I always try to listen more than I talk during these conversations. I leave the conversation open. I offer to talk again, okay? And that's how I approach it, right? But I always start off with why I got vaccinated, right? To protect myself and my family and my loved ones, to be a good citizen and to participate in getting us out of this mess. So I make I statements, right? Not judgmental statements about why you are hesitant or won't get it, whatever. It's about me, right? We just start a couple sentences why I got it, okay? We try to clear up any science, right? the things about how it works, what the safety is, debunking myths, right? This is going to change your DNA or anything crazy like that, right? Tell them what to expect, full disclosure, what some of the side effects might be, and then absolutely direct them to vetted sources of information, right? I think one-on-one conversations with healthcare providers are what's gonna sort of, the Times called it hand-to-hand combat, like one-on-one. We gotta talk to these folks and turn them. So I'm just going to run through really quickly how I've got 4 or 5 slides here about how that conversation with the hesitant can go, helping them understand how the vaccine works, how Pfizer and Moderna are just messages in a bottle, pieces of RNA that get injected, that are coated with fats. They get injected. Your body recognizes it. Some special immune cells recognize that piece of protein as foreign. They engulf it, and it takes that message to start producing spike proteins. Those little red things, we've been looking at the cartoons all year, start producing spike proteins. Your body takes helper T cells and goes, ooh, those are B cells, and says, ooh, those don't belong, and starts making antibodies. And so those antibodies to the virus in the bottom right-hand corner are the ultimate goal. That is the vaccination event, is to produce lots of those antibodies, so that if you see the infection naturally in the grocery store or out and about, your body's ready to roll. That antibody is circulating in your body after vaccination. It can grab onto those spike proteins and mark it for destruction. Okay. For J&J and AstraZeneca, the adenoviral vector vaccinations, you can let them know there's a double-stranded piece of DNA inside of a hollowed out viral vector. That's what's actually in the shot. And then essentially the same thing happens. It gets injected. It migrates to special immune cells called dendritic cells. They harvest that machinery. We take DNA to make RNA, to make proteins, and then the same thing happens. You get all these circulating spike proteins, and your body produces antibodies to them. Okay, so the vaccines largely are messages in a bottle. There are some vaccines around the world that work differently. They're purified proteins or inactivated virus or whatnot. One of the best sources for all these pictograms has been the New York Times. If you just type in New York Times vaccine tracker, you can get all these great pictograms. I talked to folks about, what's out there now between Pfizer, Moderna, J&J, and AstraZeneca, large and prevalence of those, looking at Novavax. We're going to have more platforms coming in the fall. We've had these rolled out for some time. They are the absolute takeaway message here is they are nearly all 100% effective at preventing death and serious illness. Okay, I mean, these things are crazy effective. I try to discourage people from vaccine shopping, right? Maybe this one's 70% or that one's 90%, whatever. They're apples and oranges. They were trialed in different locations around the world at different times with different variants. The takeaway message here is the best one for you is the one you can get the quickest. And they are all nearly 100% effective at preventing hospitalization and death. Then I walk folks through, one of the main things is, oh my gosh, this went too quickly. It can't possibly be safe, right? And I want to walk people back from the too quickly thing, because these vaccines have been 20 years in the making, 20 years plus of basic science research. And it started after September 11th, largely. So I wear hats as a biosafety professional as well, and spent a lot of time thinking about biosafety and biosecurity. And after September 11th, the world woke up and went, oh my gosh, we have got to be ready for acts of bioterrorism. And so US agencies and agencies around the world, DARPA and BARDA, were given the express mission and funding to come up with and develop vaccines. It was 60 days from new agent emergence to benchtop to arm. We want a vaccine in 60 days. Okay, and it should give everyone chills to know that Pfizer and Moderna had candidate vaccines after we had the sequence from Wuhan last January ready to roll in vitro in 4 days, right? They were in animals in, I think, 42 days, right? So this is just, I mean, this is crazy, right? But it took 20 years largely to figure out the delivery mechanisms, right? We knew how to make the proteins and the plasmids and get all that stuff organized. It was that super fragile shell for Pfizer and Moderna that needed to be sorted out in the adenoviral shells for J&J and AstraZeneca. So these vaccines are just faster to produce than traditional vaccines. To figure out how to purify proteins and kill virus and half kill virus and all these other kinds of things are complicated, right? The third one was probably one of the biggest factors in helping us understand safety and efficacy, but it's sad, right? So the high prevalence of disease last year throughout the world really allowed us to understand very quickly how efficacious, statistically significant outcomes, how efficacious these vaccines are, okay? So the fastest before this we've ever gotten a vaccine was mumps. It took 4 years, and generally you vaccinate people, there's such low prevalence of circulating disease, thank heavens, that you have to wait a very long time for people to get sick before you can count outcomes on how well your vaccine worked, right? Did the vaccine work or did it fail? We were able to study these things with such high prevalence of disease within months. Within 2 to 3 months, we understood how effective these were. We used existing networks to conduct these trials. There was thoughtful combinations in phase 2 and phase 3 trials. And you just don't magically enroll 40,000 people in a trial. I mean, these are heroic efforts of scientists working around the world to get these trials done in crazy speed. I mean, literally around the clock to get 50, 40,000 people enrolled and tracked and organized, heroic efforts. And then lastly, this is nuts, right? So outside of a public health emergency, when would a company start manufacturing something they didn't even have clearance for, right? So some things got sped up there. I want to take a minute to talk about J&J and AstraZeneca and the blood clots. I know it's been on everybody's mind. When I woke up and saw this pause, a couple Fridays ago, my immediate reaction was, oh my gosh. It was a little bit of panic, and then I quickly readjusted my thinking, right? Because this is the confirmation that the hesitant need to go, okay, the system works, right? So lots of different vaccination monitoring systems around the world. The United States has a very conservative system. Our vaccine adverse event reporting system had found 6 cases at the time of the filing, time of the pod, 6 cases among almost 7 million people, right? I mean, this is a needle in a haystack. It's super serious. It's super concerning. Those 6 people are very important people, but it's super rare. And the system worked to find these things, right? So that should give people a measure of comfort, okay? So on the 13th, they paused. It's a rare type of blood clot that needs to be treated differently, right? So it's a blood clot in the brain and sometimes the stomach when, in fact, you have low platelets everywhere else. So it's kind of a funny thing, gets treated differently. The pause was lifted last Friday. We're going to continue the monitoring in the States. And, according to CDC, there's a host of things if you get the J&J vaccine that you should be looking for. Severe and persistent headache, blurred vision, abdominal pain, leg pain, chest pain, shortness of breath, bruising, or tiny little red spots, okay? The blood clotting issues with AstraZeneca were very similar to J&J. The rest of the world took a little different, look at them. The risk of hospitalization due to blood clots from COVID, because COVID itself will cause blood clots, was much greater than the blood clots you might get from getting AstraZeneca vaccination, except in folks that were less than 30 years old. And so that's led to some suspensions and then restarts. For instance, Denmark has not started using AZ again. Some countries have restricted it to, folks, over 60, over 50, over 55. So some various things, but suffice to say, we're watching. We know how to treat these things, and the risk of blood clots from having COVID is much higher. But again, I hate risk comparisons like that. We're talking about something that we give to perfectly healthy people, a vaccination. So the risk rubric is different. But I just wanted to just hit that head on so that we were all feeling a little bit more comfortable about what the system does and how powerful the observational system is to make sure these things are safe. I hit hard the myths, right? So one of the big ones I hear is this thing is going to alter my DNA, right? It's going to make me infertile. These things do not, the Pfizer, Moderna, the RNA vaccines don't even enter your nucleus where your DNA is. The J&J and AstraZeneca vaccines, they do enter the nucleus of your cell, but they don't integrate themselves into the DNA. In fact, one of the major trials, one of the major scientific challenges of the past 20 years, literally been figuring out, is how to get these things to stick around long enough to make enough protein. I mean, so the RNA is very short-lived. The DNA platforms are very short-lived. They're degraded naturally within a day or two, okay? So they're not going to permanently alter your DNA. They don't incorporate themselves into the DNA, okay? They don't contain live virus. They're not going to make you sick. They're not going to make you have a positive molecular test, okay? Hopefully they will get you to some positive antibody testing when we sort out what an immune passport looks like. The vaccines don't contain microchips or tracking. I know this is crazy, but some people think this, and we just need to say, geez, that's not true at all. And then we need to encourage folks to participate in the two-way communication. So federal and state and all the government agencies largely have some way of communicating adverse side effects so that we can in fact catch 6 people in 7 million that have something very rare that needs to be talked about. And then I usually close with what to expect. Like, here are the side effects. Like, no fooling, your arm's going to hurt, you know, likely it's going to be red. And maybe after the second dose, it's going to be worse if you don't have one of the one-dose shots like J&J. Fever, like maybe a stomach ache. Just again, transparency is critical. And then letting folks know how to prepare and cope with the side effects. It's going to last maybe a day. They don't, docs don't really want you taking, you know, ibuprofen or Tylenol, these kinds of acetaminophen or ahead of time. You know, if you need something after, totally fine to take something, you know, sleep it off for a day. Okay. Folks have always been asking me these past few months, are we going to need booster shots? And the answer is probably likely. What frequency, we don't know. You know, all the major manufacturers are pulling together booster plans. It's probably going to be like our flu booster, you know, maybe on a year cycle. Hopefully we will get ahead of the variants fast enough that we don't need boosters so often like we do with the flu shot, but, you know, to be continued. But, you know, putting it out there. So we're going to leave this largest bucket of controls for elimination, and I'll talk for a few minutes about engineering controls. And I again, focusing back in on the airborne component, right? So large droplet control means something different than airborne and the smaller micronuclei control. And I think it's just getting back to our HVAC basics. We were laughing the other day, indoor air quality or indoor environment quality has just every decade, it just comes into fashion, goes out of fashion, right? It comes into fashion for energy reasons. It goes out of fashion. It comes into fashion for productivity. We know people that have better indoor air quality are more productive. Comes in and out of fashion for infection control. And so I'm hoping this revival of getting back to HVAC basics will be here for a while. Verifying that your systems work as they were designed, you know, following ASHRAE and REBA and all these, the basics, which is just making sure you're getting folks enough fresh air, you know, making sure that you're lowering recirculation, raising air changes maybe from 2 to 3, 3 to 4. Maybe in some of the older stock, it actually just means opening the windows, right? Using higher grade filtration. You know, I get that a lot of older systems can't handle MERV 13 or 14, but even like getting from an 8 to a 9 to a 10 with some of the other, you know, fresh air, you know, increasing air changes, you know, it's sort of like, what can you do within the rubric of, you know, what your building system has, and then consideration for adding portable air filters in spots where, you know, you've got dead air, you know, offices that have been repurposed from broom closets, maybe where there was no ventilation concerns, conference rooms, you know, a lot of the rules around conference rooms, like how many people can we put in a conference room? You know, what's the ventilation look like in that room? Maybe in some of those closer settings, some portable HEPA units might make sense in the short term. When we think about, again, that large droplet control, we're thinking about barriers, right? Keeping your bugs away from me, but the barrier also serves as sort of a reminder to stay a little bit away from each other. I've got clients last year who's put plexiglass everywhere, okay, and maybe have a little bit of remorse on that right now. You know, it's got to be cleaned, it's got to be maintained, and in fact, maybe some of the plexiglass actually circumvents or redirects airflows. Okay, so just having a good look at your plexiglass as we re-enter is probably a good idea. Reevaluating some of these technologies that we've had around forever. No one can give me some good scientific data on some applications. So ultraviolet or UVC light. We've used it in the labs as a biosafety professional. We use it in lab in very targeted settings in healthcare. It's awesome. Sometimes in HVAC systems, we use it to keep coils clean. You know, there's been upper room UVGI in, you know, getting a dose of UV light, and it's radiation, right? That's how it kills bugs. In a flowing system can be difficult post hoc if it's designed in, maybe. A lot of situational considerations there, especially same thing for bipolar ionization. I know it's out there. The literature isn't as good or as old as UVC necessarily, but really having a think on some of those things before we spend crazy amounts of money on that. And then literally I've spent the last year debunking all kinds of crazy things. And so just be careful. Sanitation tunnels, right? People are going to walk through these blow up tunnels and we're going to get sprayed with quatracidal components and things like that. And so just being mindful of, you know, what people are selling out there. Administratively, thinking about, you know, the new cleaning guidance, again, with the lower risk of fomite transmission. Hand washing, absolutely the cornerstone of public health, shouldn't go away. You know, continue dedensifying and distancing where it makes sense. And then you're just going to close with mask wearing. I think, again, masks are here to stay, at least through the end of the year. They work. Like I just, there's no even conversation or scientific debate about masking. They just work. And making sure folks have a good fit on them is critical. I love these diagrams. Whatever whether you've got a surgical mask or cloth covering, whatever it is, the objective is to get it to fit tight to your face and get rid of those gaps on the sides. And so you can do that in one of two ways. One of which is to double mask, which is a little burdensome, but even just a simple in that far right knot close and a little bit of a tuck in can get it fit to your face. It improves. I mean, the efficacy numbers, I've got the link in the bottom here from the MMWR. The efficacy in particle reduction is amazing with just a simple face fitting. And so I'll just close with making sure everyone's taking a good look at their programs. You know, you've got things written down. Have you looked at it? Have you been reevaluating and adjusting? Have you been documenting that what's written on paper is what's actually happening in the office floor or the manufacturing floors, wherever it is? That's going to be one of your best risk mitigation tools, making sure that you're doing what you're saying doing and that rubber, you know, as we say, rubber's met the road. And with that, I just want to thank my team here at Colden and Claire for the invite, and we'll take some questions.
Thank you, Shannon. Great information in there. We've got a few questions coming through, but we'll start off with one that I know you'll understand is close to my heart. So in terms of looking after long-term sick, there's going to be lots of you know, challenges around people's ability to return to work when they've either had COVID or perhaps they're suffering from long COVID. I know that you know, the vaccination can potentially have an impact on people with long COVID. What are your thoughts on that? And could it possibly be used by people within the workplace to support people who are suffering long term?
Yeah, Claire, I mean, you just brought up this point, which is that, so just reading some review articles on long COVID, and we don't know much at all, except for the fact that there are people suffering many months after they've quote unquote recovered, including a fair portion of folks that have had mild cases. They certainly were never hospitalized, experiencing symptoms many months past, the very early inklings, largely anecdotal, is that the vaccination has been helping, 30 to 40% of people that get it are showing anecdotally some signs of improvement and resolution of symptoms. So we're going to be watching that very closely. But and for sure, even if it's not helping with the long COVID, we want to make sure that we're encouraging folks that have had COVID. You still need to get vaccinated. You don't know what kind of variant you had. You don't know what sort of antibody protection you built up. We really want to make sure that you are fully immunized, and the way to do that is with a vaccination, even after you've had COVID.
On that question of vaccination, somebody asked, why are expectant mothers advised not to be vaccinated, if that's the case?
Yeah, expectant mothers in the States are not, they absolutely, the OBGYNs here have been recommending that they get vaccinated. Again, it does not alter your DNA. You can't pass to next generation. Interestingly, you can pass the antibodies after you've been vaccinated. You can pass those antibodies to your baby in utero and through breast milk. And so if you go to the American College of Obstetrics and Gynecology, they have position statements right on their homepage that you can direct folks to. The other issue is that we know that pregnant moms are super vulnerable to the health effects of COVID if they're infected. So we absolutely are recommending that they do get vaccinated.
Okay. Thank you for that. But just a question here, I suppose it's a moral question perhaps, but thinking about the number of people who will die from flu every year, if we accepted that as a society, do you think we should begin to accept that there will be a level of mortality from COVID going forward? Or is it just too infectious to manage without these controls?
I think so. Probably the answer is all the above. It's this this virus is way more infectious and it's way more deadly than your garden variety influenza A or B, for sure. But that said, I do think we're going to have to get to a point where we're going to have to recognize that this is just going to move from pandemic to endemic, and people are going to succumb to this every year. It's circulating. I don't think we're going to get rid of it. We're going to have to stay on top of the boosters. I mean, my sincere hope is that they can start combining the flu and the COVID boosters together. That's actively being looked at and developed now. But yeah, I think that is probably a sad reality, is that this is going to be with us. On the bright side, we're, hopefully we'll every day we'll get more people vaccinated. The treatment and the management is getting better. Our understanding of what to look for on who needs which treatment, right? So we've got this suite of treatments, but who needs even when to deliver the antibody treatments, right? As we sort of learned pretty quickly, it was not going to be valuable in someone that was hospitalized. It was sort of someone who was just sick enough pre-hospitalization to get the antibody treatments. And we're, more antivirals are coming up. We're pulling some old ones off the shelf. So, I mean, hopefully we can get it down to at least flu numbers every year.
Somebody's asked whether it's medically proven that the vaccine doesn't have a side effect in men. Now, from what I've seen, people that I know are similarly affected. Is there a difference between the effects on male and female people who've been vaccinated?
It's a great, complicated question. So some of the J&J, I think we had 2 or 3 men that had the J&J in the system that had that super rare type of blood clot. I'm not as conversant with how many men were in the AZ pool. I know there were some, I'm not sure which percentage, but clearly it is definitely affecting women more than men. Women have a documentable, more robust immune system. Most autoimmune diseases, on average, affect women to a higher percentage than men. So there definitely is something different going on where the men seem to be less affected by the blood clots for sure. But scientifically, the vaccine works the same in men and women. I don't know if that was part of the question. I think I got it. Did I answer that one?
I think so. Yes. I mean,
Okay, yeah. But it's
it's
a
a
complicated,
complicated,
important one. Yeah.
certainly. So somebody's asked your views on lateral flow testing in the workplace.
In what sense? Like just testing everyone or
Well,
PCR?
they haven't elaborated. John, if you'd like to send that question in again, we'll try and get through, get to it again. I was just wondering. I know you mentioned actually using valid sources of information, and when you were talking earlier about developing policies, testing policies, and vaccine policies. Are there specific places that you would recommend other than the WHO? And just wondered if we could just help people think about all the different aspects of developing those policies.
Hmm. Yeah, the World Health Organization, the US CDC, the UK's National Health Service. I think it funnels back to so wherever we are, we got to follow local guidance and or federal guidance, whatever that is. And I think you should start with those agencies. But I would direct people to the World Health Organization first. I think they've got some great consensus documents. They've got great vaccine education documents, posters. I also think one of the best vaccine FAQs I've seen is through the New England Journal of Medicine. So if you just Google New England Journal of Medicine vaccine FAQs, I think that it gets pretty granular. It's got some good references, so you can sort of go back to the source for the answer. But yeah, I probably would largely stick to the WHO.
Okay, and it's interesting where we talk about the facts and the figures around it, but as we're going to discuss next week with the panel, there's so much else to consider about people's feelings about things, how you communicate all of this information, and how you have those helpful conversations that will inform your policies as they evolve, I suppose. They need
Hmm.
to be revisited regularly as things change.
Yeah, nothing about this past year and a half has been static. I mean, every day it's this large dose of science, large dose of policy, um, and all those things which may be semi-concrete mapped onto people, right? I mean, you can be efficient with everything but people, right? How do people feel about the science? How do they feel about the policies? Are they going to participate? Do they believe you? You know, complicated days.
John's come back and said regarding the lateral flow testing, yes, some employers have asked about testing everyone in the workplace. Does that clarify
Yeah,
the question?
yeah. I think So here's the rub with the vaccination, right? So it's like, are you gonna have more carrots or more sticks? Maybe early on it's to have more carrots, right? And a couple months from now, it's sort of like, okay, what's your hesitancy? Do you need a stick? And I think one of the carrots actually is um, you can opt out of testing, right? So I've got clients now who are saying, look, you don't need to get that, like higher ed was testing twice per week. And they're saying, if you're vaccinated, you can opt out of testing. That's fine. And I think that's scientifically valid, unless you have vaccinated and developed symptoms. If you're vaccinated, we're not asking folks to quarantine anymore if they're traveling or have been a close contact. So those are some of the carrots associated with getting vaccinated. And I think that the universal testing really shouldn't apply to the vaccinated anymore. I think that'd be a nice carrot.
Okay. There's nothing else coming in at the moment, Shannon. So have you got any
Okay.
closing remarks that you'd like to make, or perhaps you'd like to let people know about the short survey we're going to do to find out how they're finding the
Yeah,
situation, their challenges?
yeah, sure. So I guess it's just colleagues to just hang in there. I know it's been a long year and a half almost. Just hang in there. and fight the good fight and stick with the basics on what we all know the controls, the hierarchy of controls looks like. And so next week, I'm looking forward to a panel discussion, and Claire's going to be sending out a survey, and we really want to hear from you. I think at a high level, understanding where your challenges still are, and getting people back to work, and the controls and the conversations you have, the difficulties you're having with policy or science questions. And then conversely, maybe you can share with some things that are going right, like some things that have totally worked for you that we can share in that forum next week, about some creative things you've done to get people back and comfortable, and some unique policies that have gone over really well. That would be great to share in that survey.
I think that'll be a really interesting session next week. Looking forward to sharing that with everybody. So look out for the link to register for next week if you haven't already. Shannon, are you happy to share your presentation as you did last time, this time around?
I sure can.
Great. Okay, we'll send that out to you as well, everybody. Look forward to seeing you again then. So thank you again, Shannon. A really great session. Have a lovely evening.
Yeah, too.
Okay.
Bye, everyone.
Bye, everyone.